You win the prize, Dave. You're first. Hang on one second. I don't have your audio again. Here we go. All right. We've got 45 attendees already. I'm going to unmute you, Dave.
No, I think I was muted on this side.
Oh, I'm sorry. Yeah, now I've unmuted you. That's right. Fix the hair.
No chance of that. Right?
While we're waiting on everyone to hop on, I just want to give a quick thanks to all you attending right now, and many more will be hopping on as we go into the next minute or two before we actually officially start. If you will, type in your name and where you're from. We want to know where everyone is viewing from and having an interest to participate tonight. So please feel free to type that in the chat, which is where we'll be having additional questions as well. We got Nashville, Tennessee, Montreal, Georgia. All right, Virginia Beach, Terre Haute. Hi, Adam. Delaware, Tampa, Toronto. Michael. Hi, Michael. Hadn't seen you in forever. Hi, Doug. Furloughed yesterday after 7 weeks. Unfurloughed. Oh, congrats, Doug. That's exciting. Hi, Gary.
Jason.
Let's get your, there we go. There's your audio. You got your audio. Ontario, Canada, St. Petersburg, Florida. Ottawa, Rocco from Ottawa, Tennessee. Redding, California. Hi, Mark. We're just going to wait just another minute or two before all of our, or for the rest of our panelists to hop on, and then we'll begin. Excited to have everybody here for this Q&A. Hi, John. Lisa from Toronto. Hi, Jessica in Ohio. Stephen, Vermont. So far, it's North American dominant, but that makes sense why. Madison, Wisconsin. Northern Michigan. Hi, Greg. Washington, D.C. Minnesota, Orlando, Delaware. There's our first Asian Madhvi from India. Alvin in Hawaii. All right. Tokyo, there's our longest traveler. Excellent. Gary, I hear the numbers with the virus are staying low in Georgia in spite of opening first, huh?
Well, it just depends on where you look.
Is that right?
Yeah, there was some argument, some misrepresentation. Yeah, yesterday. I don't know how that turned out.
It depends whether they release the numbers.
That's right. They gave you the numbers in sequential order or not.
They just stopped testing altogether. There's no new cases.
We just kind of make it up as we go down here, you know.
There you go.
They just released the numbers from February.
That's right. Yeah. Iran. Hi, Javad. Very good. All right. Well, just waiting for our last two panelists, and then we'll begin tonight.
It looks like Scott and Cora bailed on us.
Yeah, they're thinking that's it. Gary and Dave can take it from here. Somehow I don't think Scott's intimidated or worried about this. Yeah. Hi, Dimitri. Okay, Dimitri wants to remind everybody that in the chat, instead of typing just to panelists, which is the default, change that to all panelists and all attendees. So any additional questions can be seen by everyone. Let's see here. Let me look for you, Cora, and thanks for saying that. I'm gonna promote you, there we go, to a panelist. That may be why. Scott, let me see if I can find Scott here. Although I think he should have, there we go. Cora, can you hear us now?
I can hear you. Hold on. Let me put the video on.
There you are.
There
we
you
go.
Hi.
The gang's almost all here.
Scott's calling me.
Oh, okay.
Hello?
Does he need a resend of the?
Hang on. He can hear us and see us, but he can't get in.
Okay. Let me see.
I have the
What's,
same issue.
Hang on. Jason is looking for something.
what's
Try-
his
keep
username?
trying. He's still trying. You can
Where's his
hear and
username?
see, but can't get in.
Yeah, that means probably he's an attendee, which
Yeah.
I've got to find him. If his name is not obvious on the, can you text him and ask what his username is?
I could throw a couple of options out there for you.
Keep it clean, Gary. Keep it clean.
Not what username you would give him. It's what he's given himself.
Can people hear us right now?
Yes, they can.
All right. I got to be careful.
That's right. Yes, you can, Javad, you can ask a question in the chat. That's the best place to ask it. If you will, make sure that you designated that in the little blue button on the bottom right. You'll indicate who you're asking the question to. So whether it's to all panelists, all attendees and panelists, just to one individual. So make sure that you click that and choose the all panelists and attendees in there.
Hi, Cindy
Thanks for the
Larson.
question.
I remember you.
All right, if we can
Great
find
name.
Scott, we're ready to go. Sorry, folks, one more moment.
Oh, there we go. Okay.
Yeah?
All good, Cindy.
Herbowy 7.
There he is. All right.
You got him?
Yep, whoops. Cancel that. Here we go. I need a drum roll. Here he comes. Fashionably late.
Exactly.
Gary Jr.
Where's Scott? He'll be here in a minute.
And Scott, if you can hear us, go ahead and share your video when you're ready. Trying to unmute you. There we go.
All right.
There we
Audio.
go.
There he is,
And
Herbowy
video.
7.
Yeah,
There we go.
I've been trying to join this thing for about the past 6 minutes. It keeps asking me for all sorts of stuff, and I don't know why we were on before and everything was fine. So
Yeah.
okay, here we go.
That's all right. Here we
There.
are. There we go. We can all go on. Okay. All right. Let me just hop in here as it's just a few minutes after 6:30 now. Welcome to this special edition, Case Conversations, in partnership brought to you with by the McKenzie Institute USA and by the Mechanical Care Forum. So I'm tickled to be here and be able to host this Q&A, moderate this with our panelists, Dave Oliver, Cora Aytona, Gary Dykes, and Scott Herbowy. Thanks, guys, for being here tonight.
Welcome.
Thank you.
Welcome.
For having us.
We have a good number of questions that were offered, and so we're going to be managing those a bit by category. We'll try to make sure that we address all those major questions that were asked. If you have additional clarification that you'd like, or if you have something there, we would encourage you to jump in there and ask additional questions on the chat, and we'll be trying to handle as many of those as possible. So we have a 44-year-old male, which is the patient that we're focusing on tonight. That was videoed to all of you that you've been able to observe. And he was complaining of anterior to medial right knee pain. Scott was able to assess this patient. We have 2 additional sessions that will be released each week. Later this week will be video 2, and the following week is that 3rd video, so that we can all see the follow-ups and how Scott managed and educated the patient to a good outcome, just for some points that we can all learn from and discuss. So tonight, we're excited about you all joining us here tonight. We want to welcome you, and we look forward to a good conversation for us all to learn together. This was initiated by Scott and by MIUSA, Stacy Lyon, because of this challenges that we're all dealing with this virus pandemic and the lack of courses in a way to support our MDT community. So again, we're glad you're here tonight with us. So let's just take the bull by the horns, and we will first address that obvious question that was asked most frequently. And Scott, share with us your thought process with this patient case in terms of screening the spine. This was a knee patient. It sounded like a knee problem. We all understand, however, though, that some patients can have extremity symptoms alone without any complaint of spinal issues, and yet they may have some of their symptoms or all of their symptoms driven from a spinal issue that's then addressed and resolved. So can you talk a bit about your rationale and your thought process in screening the spine with Brian?
Yeah, Jason, thank you. Well, first of all, this video was done probably 7 or 8 years ago, which is well precedes the Expo study, as we all know. And that's firstly, but I mean, we've always said, you know, screen the spine. I think we do a more careful job of that now, especially with the data we've had from Expos. I mean, certainly if somebody comes in and has forearm pain, I'm screening the spine to me there means many, many repeated movements. So, you know, my take on it has always been there's varying levels. And I think I know when we've had meetings together with faculty, there's varying opinions on what exactly it doesn't mean to screen the spine. And I think at this point for me, you know, 7 years forward, at very least, I would look at lumbar range of motion, but do I always do repeated movements before I go to the extremity? No. And I think in this case, it's actually played out in that in the Expo study, the area that had the least amount or the least possibility of coming from the spine was in fact the knee at 25%. So if I've got a 75% chance of being right, I might as well go there first. And you know, I think my point is you can't be dogmatic about these things. And if I go to the knee, and there were a lot of clinical findings with this. He had quite a severe loss of flexion. There was a loss of terminal extension. He had a large functional limitation in his squat. If you don't see those things, you can always quickly shift gears and go back to the spine. But having seen those, I think that it's prudent, especially now, 75-25, well, let's go ahead and take a look at that knee.
Yeah, let's hear from the other panelists just on those comments. Dave Oliver, what are your thoughts?
Yeah, I mean, when I'm assessing a patient, there's a few key questions I'm always going to ask the patient, and I always think it's like a sliding scale. You know, based on the history, based on the clinical presentation, is going to dictate how much time I'm going to spend in the spine. If I have a patient that points at their knee, has knee loss of motion, doesn't report any back pain, you don't see any detectable loss of movement of the spine, then I'm going to delve into the extremity, but also have the backup that if I don't find anything in the extremity, I can always back up to the spine. If a patient comes in with mid-thigh pain, buttock pain, a history of back pain, loss of spine motion, I'm spending 2 or 3 sessions probably in the spine, and I won't even be examining the knee in any great depth at that point.
Cora, any additional thoughts on that?
Yeah, so I agree with Dave and Scott. Now with the XPOS study, everybody's looking at the spine. You know, I think we're becoming a little bit more dogmatic about making sure that we clear the lumbar spine. And I think based on that study, there are 5 strong indicators that what you're seeing might be coming from the spine. What are these 5 indicators? Number 1, the patient indicates in the history that they're worse with sitting, worse when still, worse with bending, and certainly Brian didn't mention any of those. The presence of paresthesia, he didn't have any paresthesia. This posture correction, I don't think posture correction was done during the case, but I think that's one strong indicator that it might be coming from the spine. Do they affect their symptoms with posture correction? Is there movement loss in the extremity? So obviously if the patient doesn't complain of movement loss in the extremity, then you're less likely to think this might not be or less likely to think it's an extremity problem and more likely to suspect the spine. and obviously if there's some spinal movement loss. So for me, I would look at the spine range of motion, just like Scott said. So that's one of the things that I would do, even if they do not complain of back pain, at least take a gander at their spinal range of motion. But if the patient primarily complains of a very local problem in the knee and the history doesn't point to anything spine related, and they're there for that, I think it's easy to lose that patient. Got to be very careful in wasting too much time in the spine. If their complaint is the extremity, you can easily lose that patient. So just like they said, if you pick the extremity, go through it. If there's any suspicion at any point during your assessment that it may be something else, it might be the spine, then you can always go back to the spine.
Mm-hmm. Gary, can you think of a patient in the recent past where you did brush past the spine? It seemed to be, one of those patients that you felt like didn't have any history. They had a significant obstruction. It was the type of or history that came on from a sudden event that seemed to be reasonable that it should be the extremity, and then you discovered later that I had to go back to the spine, and there was at least a contribution from it.
Absolutely. Monday.
Yeah, okay.
Monday. And so, and it's really an interesting case to me. Is a lady came to me with a total joint replacement, and she had a persistent knee complaint. I mean, who doesn't see that at 3 or 4 months out, right? And so, a lot of that, she came to me as a referral from a friend, because you're like, oh, you're still having trouble. You need to go see Gary. You need to go see my therapist, that kind of thing. So when she comes in, I look at it as, okay, I don't know her. She's got obviously got a knee history. So let's look there. Let's treat this as it seems. And it's, I would think it's so it's a surgical, deal. And so take it down that path, and a visit or two later, as I look at the knee doesn't behave as I think the knee should behave at all. And so, when that happened, I looked at her and I said, well, we're about to probably get outside the box a little bit. And she said, okay, I'm open. I'm here for that reason. Let's figure it out. And what I found then as I looked further into her was that she had baselines at her ankle. She had baselines at her hip. And as we repeated, she had no complaint of back pain, but she did have baselines at her hip, power issues at her ankle, power issues at her hip. And she had an inconsistent loss of motion. I mean, a motion at the knee that would change with, some of what we were doing, but it was inconsistent. So we couldn't classify it at the knee. And so as we tested the lumbar spine, power in the hip returned, knee range of motion improved, and the ankle power improved. And it was like a light bulb went off for her, for sure, me too, because it was really interesting, because I'd gotten steered down the wrong path just on the fact that it was a surgical thing, right?
Yeah, Mark's asking the question now in response to your comment, Gary. What was the clue that tipped you off that the knee was not behaving like a knee should?
So her biggest complaint was that her knee wouldn't flex as she thought it should, wouldn't bend. And so, that far out of surgery, I would look at it and I thought, okay, well, if this is this far out of surgery, this should behave almost as a dysfunction. So it should be a produce no worse. So I sent her out doing, she wanted flexion. So here's how you have to load it. This is what you have to do. She comes back, she's exacerbated her complaint. And I'm thinking, okay, well, that's not what I expected, because the dysfunction should be produce no worse, in range pain, no lingering symptoms, blah, blah, blah. We all know that. So I said, okay, well, that may suggest that we've got a different type of scenario in that total joint, i.e. could be derangement. I gave her the wrong thing. So we looked at extension, right? Repeated that, much like what Scott did with the video, and got inconsistent changes, which is not what you'd expect with what a derangement should be. I mean, they can be inconsistent, but they're at least predictable. And so it was nothing like that. And so I then just took a step back and thought, okay, well, what haven't we looked at? And so then we looked further up, and I think we got our answer.
Sure. Very good. Scott, can you think of a patient that it appeared like, here they are with an extremity complaint. You did start by screening the spine. You did see a significant improvement or response that gave you justification to have that patient spend 24, 48 hours of working through repeated extension, let's say. And they came back and no substantial lasting changes, that you later then found that, this is primarily driven from the extremity joint.
So saying starting with extremity, getting improvement, and then the improvement.
Sorry. Yeah, no, starting with the spine you saw some initial improvement that appeared like, aha, here we've got a good start. This may be an XPOS. However, after 24, 48 hours, it was just momentary improvement, nothing lasting, nothing convincing or a cumulative improvement. And later you found, no, it was primarily just the extremity or solely just the extremity.
Yeah, this past weekend, doing a private course, this is one of the craziest things I think I've seen in a while. A young woman, 17 years old, very athletic, a runner with almost like compartment syndrome type complaints in the right lower leg, anterior, posterior, and lateral calf symptoms. Not constant though, so that's not typical of compartment syndrome. Intermittent pain, worse with running, worse in the morning, no effect with sitting. But when we start screening her, great range of motion, great no movement loss in the spine, but absolutely huge losses of motion in the hip. Flexion, internal rotation, weakness around the hip. We belted her down because of her flexibility, and she did a bunch of press-ups, and the hip motion was completely recovered. She went out and ran and said, yes, it feels better. And she came back the next day and she said, you know, I'm quite the same. And her motion again was limited in the hip. We went through extension again in the back, and now it didn't change. So we went to the hip and improved her motion, but at that point didn't change her symptoms. Then she came back the third day, and now it starts to get bizarre. Her hip is blocked up again. Her lower leg felt pretty good. I had her jump up and down literally 5 repetitions, and she said, yes, my lower leg is killing me. And on re-exam, her hip motion was now full. And I said, what in the heck is that? And then had her do a lumbar extension, blocked her hip motion, and blocked her hip motion again, didn't affect her pain. Had her do extension in lying with her knees bent, and her lower leg pain went away, and she further obstructed her hip motion. So now it starts turning out that make her pain better, make her motion worse, make her motion better, make her pain worse. So the last thing we gave her was, let's go with make her pain better. So we've been back and forth between spine and not only her lower extremity complaint, we also loaded the ankle, which did nothing. We loaded the knee, which did nothing. So she's got these distal symptoms, and we're running around between the hip and the back, just going crazy. Started with the spine.
Yes, yeah, and my point in asking those two flip questions is because I'm hearing you guys enough talk about how you may not get it right that first time, as long as you let the symptoms drive your reaction. And there's some consistency. We talked a bit about recording, or before hopping on and recording this, how you guys are fairly deliberate. Talk about that for just a moment, Scott. With this patient, you chose to not do that. You talked for a moment about you have a pattern, you have a system, you have some methodological, or you're methodical rather, in how you assess.
Yeah, I think some, question came up about, why did you go here first? Why did you go there first? And especially in the extremities with, especially the ball and socket joints with such variability in motions, I like to do things very, very consistently so that I have a baseline to work off of in case the results aren't what I want. For instance, I always say functional internal rotation, put your knuckles up and run it up the back of your hand, not because that works every time, not that because it's necessary, because if I'm not paying attention and one time they have their knuckles on one side of the spine, one time they have it on the other side of the spine, if I'm getting variability in responses, I have no way of quantifying that. I think there was a question that was asked about the position of the foot when we were doing the knee extension. And I just start with the patient, putting their foot in whatever feels neutral or normal for them. And then I can vary that later on.
Okay. All right. Any other comments on that being methodical? I know, Gary, you've mentioned that before as we've discussed. Go ahead, Dave.
I mean, I think as well that being methodical, I think that the method is based on experience. Having seen lots and lots of patients, I I think you tend to go with the pathway that works for the majority. And then if it works, you continue down that pathway. And if you hit a dead end, then you can start to deviate from that pathway. But if you start with that standardized pathway, then you can build from that.
Yeah, and can I jump in, Jason? That's absolutely, I remember working with Robin in New Zealand, and when we would ask him, why did you do it that way? And his answer was just what Dave said. He said, that's what I found worked most often best. And if I need to change it, I can change it from there, but I'm always going to start with that based on the experience of not only me, but what the patients told me what worked.
And so I wonder about that clinician who's a year or two out, who's just taken Part A or Part B, who's hearing, gosh, do I have some liberty to be a little bit free with this and tend to kind of eclectically use. Is that what you're saying?
Yes.
Yeah, you have, after you've done it the right way, then you have liberty to change.
Okay, that's what I'm getting at.
Yeah.
I'm just anticipating there may be some clinicians out there who don't have 25 years of experience, and they're thinking, well, okay, do I just kind of grab a direction and a load and just start and kind of feel for it? But you're saying you've got a reasoning behind where you're starting.
Actually, coming back to that, I mean, I think it comes back down to, you don't want to reinvent the wheel. I mean, Robin spent 30,000 patients screwing up for our benefit so that we can take it from there. And then Scott spent many years screwing up, and I'd taken it from there. And I was taught with Scott, and I saw stuff that we did on the diploma program back in 2003 that we don't do now. And it's the whole process is continuously evolving. But it's evolving based on the number of patients that we're seeing and the responses we're having with those patients. And there's things that we started to do, and it was like, okay, so then I'm changing my methodology. I'm just kind of like, okay, I'm seeing this to be more effective, so we're going to go there, but then build from there.
Good
Can
comments.
I also add something?
Yes. Go ahead, Cora.
Yeah, so I think just to piggyback what the others have said too, is in the extremities, there's just so many movements to play with, and it's so easy to spend a lot of time assessing, and you don't have that privilege in the clinic. You don't have 2 hours to play with repeated movements. Plus, the patient probably wouldn't want you to do that anyway. So that's why I think it's important to be very structured and to follow clues in the history, right? So for somebody who doesn't have a whole lot of experience, they just finished school, they've got 1 or 2 years of experience. I think listening to the history, what in the history in the better and worse section might clue you into thinking this might be a good direction to pursue. So often in my experience, the modus of injury, or if there's no apparent reason, ask them what they were doing that brought on the symptoms. Like just recently I had a surfer guy complaining of right anterior hip pain, and what does he frequently do? Popping out on the surfboard is externally rotating the hip in flexion on the right side. So then I'm thinking, okay, so if there wasn't any significant movement loss, then I would probably look at extension and internal rotation as a probable directional preference. So certain clues you can pick up from the assessment.
Yeah, very good. And we'll get into some of that. I appreciate you bringing that up, Cora. Let's talk about some of the questions related to history taking. And I see a few questions coming in on the chat, so we'll do our best to get those answered as well. Bear with us. What's the intent of asking if the knee is worse the next day after running, or if it quickly subsides or it lingers after running? Scott, what was your thought process there?
Yeah, Brian's pain was pretty local, and typically contractile problems, the pain will be very local. Contractile problems, when you overload them, will tend to be worse the next day. Derangements will tend, when you overload them or exacerbate the derangement, will tend to hurt immediately upon completion of the activity, and then continue on for some time frame. A few hours, could hurt for a couple of days, but that okay afterwards, but hurting the next morning is really indicative of a contractile problem.
Any other thoughts on that from the other panelists?
I agree.
Okay. This is much too easy. Scott.
Jason, extremities, really, what it comes down to, we're either looking at derangement or we know dysfunction, specifically contractile dysfunction, has a much higher prevalence than dysfunction in the spine, or we have that, that category that none of us like other. So most often in the spine, you're really looking at, is this derangement or is this contractile dysfunction? And those questions in the history can really help steer you in the right way in your examination, in your mechanical loading exam.
Okay. We're taught to be formulating in our mind as we're taking the history, and at the bottom of page 1, we should have it funneled down to a couple, 2 or 3 different potential. When you were going through this, with Brian, what spoke to you most significantly that led you to believe what you were thinking was the classification at the bottom of page 1? Scott?
I think his inability, he talked about the inability to squat. That was a big problem. Now that certainly can be a derangement. That certainly can be a contractile problem. So, really had it narrowed down to there. And when you start examining and you see that type of movement loss, the contractile problem is not going to do that. So pretty quickly, remember, before we got repeated movements, we do have those baselines, movement loss and functional baselines as well. So, we want to have a thought at the end of a history, but you also want to be flexible in your examination to make it what it did, to have it come out what it is, rather than what you want it to be. One of the biggest challenges we had with diploma students was teaching them that everything is not a derangement. People love derangement; they get better, and boy, some people would struggle mightily trying to make things that weren't derangements.
So the question came up in the chat just a moment ago. You get that patient who says, "Hey, I'm about 20% better." That's almost on the fence of, is it statistically significant change or is it not? Dave, when you have a patient that shows it's not the same, it's different, but it's not dramatically different, what are your thoughts on, have you conclusively ruled in or out anything with that kind of response?
Not yet. I mean, if and I think the question was reference to the spine. So if I've got an extremity problem and I'm suspicious of the spine and I send them away, okay, and I maybe see, I'm going to examine them in the clinic, and if I'm still suspicious, I might send them away with testing of spinal movement. If they come back after doing 24, 48 hours of spinal movements and they're saying, well, I'm 20% better, I think just being 20% better is just a very, very small part of the picture. It's going to be based on the big picture. What in the history is really driving me to push the spine? The fact I sent them away for 24 hours pushing the spine, there must be something in the history to really kind of sway me that way. If anybody comes back 20% better, then it's not statistically significant. It's kind of on the fence there. I'm going to push them harder. It's basically it's like, am I going to mess around with direction yet? No. I'm going to mess around with classification yet? No. I'm going to mess around with force. If I've been doing extension in lying for 24, 48 hours and they're reporting the 20% better, all right, I'll collect together my baselines. I'll have them do it in the clinic. I have the luxury of a repex machine. I might strap into the repex for a bunch of repetitions. I might get my hands on and overpress them and see if I can turn that yellow light green. But
you want more convincing reactions, what you're saying.
I mean, if they're coming back 20% better, I mean, are they saying that to please me, or are they actually better? Obviously, I'm going to reassess the baselines. And if I'm seeing, yeah, they are 20% better, I'm not going to change my location yet. I'm still going to stay with the spine. But I'm just like anything. If I'm confident that it's a knee, and I'm confident it's a derangement, and I'm confident on my direction that they're only 20% better, I need to do something. I've got to change my loading strategy to elicit a greener light. If I'm getting the response with moving the spine, it's 20% better. I'm going to stay with the spine, and I'm going to push them harder.
Sure. Any other thoughts from Cora or Gary?
Yeah, I always think that the change has to be significant and meaningful to the patient. And I remember Scott, before I became faculty, saying the change has to be Texas big, right? So you said that once, Scott, or more than once, right? So it has to be meaningful. So when I'm asking my patient, do you feel better, worse, or the same? I want them to tell me definitely better, as opposed to, yeah, maybe. The percentages, that's kind of, that's difficult. So if somebody tells me 20%, that 20% might be big and meaningful to somebody who's had pain for a year or two and have not had any significant improvement with their previous treatments.
Mm-hmm.
So the bottom line is, I think it has to be meaningful to the patient.
And so I have to hear you say then, you're asking the patient, in what way are you better or are you different?
Right.
Yeah.
Right. Yeah.
Okay.
And so symptomatically and also functionally, that's why we have those baselines to go back to.
Right. Scott, the questions being brought up here, or the comment was, for me, I want to be able to find that it's a derangement because I'm confident in treating a derangement. But when it's mechanically inconclusive or an MUR or whatever, something in the other category, I'm less confident to know what to do with those patients. How can you enlighten us if we're feeling that lack of confidence?
Well, I'm not confident in those patients either. I mean, it is what it is. And, again, we want things to be things. We all went into this profession or these professions because we want to help people. And we don't like admitting that I can't help you. But it doesn't do the patient any good to continue to do things when you know it's not going to help. So I think you have to get used to saying, probably more often than we would all like, that, look, at this isn't something that I can't help. But a lot of those things can be, moved on to somebody else who can help. You find out you think somebody has a inflammatory problem. Okay, a reumatologist might help them with, pharmacologically, MUR, and we now know an injection can help those people. There are some people that are appropriate and do benefit from surgery. So it's not a bad thing to say, I can't help you, when you've gone through a good mechanical exam, and that's what it says.
Mm-hmm. Mm-hmm. Excellent. Let's talk about the extremities. If we understand that this patient could be ruled out in terms of screening the spine, and everyone was satisfied, we all collectively agreed. This patient had a very subtle loss, but definitive loss, and symptoms at in-range extension. However, the flexion was most limited. When we talk about shoulders and other areas, we look at sometimes those most obstructed directions, and we start with that. Is there a reason why? And perhaps it's clinical experience, perhaps there's something that the patient said or did, or just a intuition you had. Why did you start an extension and not flexion?
I think I'll pass this one over to Mr. Dykes.
Okay. He hasn't talked in a long time.
He hasn't talked in the number one.
He's falling asleep.
Are we all? Did we start?
We were going to have Gary answer all of the questions today.
That's right.
Yeah.
I think it comes back, a lot of us, it's not always what may seem to be the larger loss of motion. How many people do you see that have the greatest loss of motion in a shoulder be flexion? I mean, a lot. That's their complaint. They didn't come in because they can't reach up behind their back quite often. I mean, it's a complaint, but their big complaint is they can't reach in the cabinet. It hurts to raise it. They can't put a shirt on. They can't reach behind their seat, the car, things like that. So the functional moves we make are, in this, here, it's not necessarily back. So it's rare I see someone need repeated movement into flexion of the shoulder. So it's just clinical experience and logic, so don't throw that out. It kind of comes back to what Scott said earlier when he was in New Zealand with Robin. These are the things that I found that work the best, the most often. And so I think the same thing with the knee, how do we spend most of our time with our knee? And, we will tend to spend more time in a mid-range degree of flexion than we do extension. And so I think there's things in the history and, and just the clinical reasoning behind that can lead you to a path. But more than anything, whatever direction you use, you're trying to understand the complaint, and you can always change that. So not to get married to any particular, thing, but do use the most logical, strategy when you're looking at these things. But when you need to change it, recognize that, and not try to fit a square peg in a round hole.
Mm-hmm. Scott, did you hear anything in this patient's report that would lead you, or that did lead you to look at the extension first?
No, I think extension, if we look at, we have some reasonable data on prevalence. And derangement in the knee, the prevalence for directional preference is extremely strong. with the exception of one subgroup, which is older patients with diagnosed, demonstrated on imaging OA. So outside of that group, extension is very, very strong. So, and my experience is, and I don't know, I can't recall the exact figure, but I know from experience that extension ends up being directional preference much more frequently than flexion. So, and you look at Brian particularly, his flexion was exquisitely painful. So, you know, we would have to say this in the diploma program with residents as well. You know, there's actually a person attached to that knee. And even though clinically you might like to push that flexion, he doesn't like flexion. Flexion hurts him. And so you put those things together, why not test extension first?
Got it.
And Scott, I think the patient is also sedentary. I mean, his job, his occupation requires him to sit. So looking at his mechanical stresses, occupation, he spends the majority of the day in sitting, which is knee flexion. So I would think if he was going to get better with that.
He also reported that it was painful getting out of the car. Which I sometimes see as an indicator when people describe it. And I don't think you necessarily asked him specifically. The question I often ask patients, you know, after you've been sitting, getting out of the car, do you have difficulty fully straightening your knee or those first few steps? And he didn't mention first few steps was bothersome in the morning, and also getting out of the car, which might give a bit indication that there may be a vulnerability towards flexion. But I would have done the same. I mean, extension is such a driver. That being said, I mean, I don't think people should get beaten up about not testing flexion. I mean, I think I always say on classes, it says, you know, choose your direction, but justify why you're doing it. And you could sit there and say, I would choose flexion first because that is the greatest loss of motion. Okay, go ahead and do it. Do it with caution because of how acutely painful it was, and test it. And if that was the right direction, you get a response. If it wasn't, you get a negative response, and then you look at a different direction.
But, and then just talk about what Dave's speaking about with the rising from the car. And I tell people, you know, people that I work with, therapists that I work with, class, whatever might be the case, is that in my mind, mechanically, I'm thinking about what is the effect of the position the joint was just in. So if you're talking to someone with a lumbar spine and they say, hey, when I sit and then I rise and start to walk off, my back is stiff and I have difficulty getting straight. Okay, what is the effect of flexion or being bent on the joints of my spine? Okay, what's the effect of being bent or flexed in my knee? Well, it doesn't perform very well. So that's probably not going to be a very beneficial direction.
Mm-hmm. Mm-hmm. Very good. We understand that in the spine, it's fairly consistent that we start with patient-generated forces, low load, increasing that load, patient overpressure, clinician overpressure, mobilization, manipulation. Do we see the same progression in extremities? Gary, since you're on the hot seat there.
Yeah, thanks, man. Appreciate it. Yeah. You know, it's difficult because I'll fault myself for this because I know I'm probably going to go to McKenzie jail for this, but I'll tend to find myself moving to some degree of overpressure pretty quickly because I know that we have difficulty getting our peripheral joints to its end range without it. And so while you can move from an active to an active with overpressure to a passive with a passive overpressure movement, sure, you can do that. But ultimately, at some point, you're going to need fairly quickly, I think, some degree of external overpressure on the joint to get there successfully. So I'll fault myself quickly or skip. So I'll say that first. But I think you'll need that to attain end range of the peripheral joint pretty quickly.
Any other on the panel that would challenge that, or at least say in my experience is otherwise?
No, I would agree with that, with one exception, which is I will look in the knee and the elbow specifically at movements without overpressure right off the bat. And the knee, and when I teach, I say, well, the knee and the elbow are brother and sister, and the parents are the spine. They're all hinge joints, so they do behave quite consistently. But ankle, hip, shoulder, wrist, I'm with Gary. I'm very, very quickly into at very least patient overpressure.
Mm-hmm.
I think we're all going to McKenzie jail with Gary for this. Yeah, with the extremities, it's very difficult to appreciate end range without overpressure. So often, unless the patient is very fragile or they're highly irritable, then I would test self-generated without overpressure. But often, somebody who's got intermittent pain, pretty sturdy joint, I'd go right into overpressure. What I would skip at times would be clinician overpressure, because I find that the patient can apply as much patient-generated overpressure as I would provide for them applying overpressure. So at times I'd skip clinician overpressure and go right into mobilization, because I feel if I'm trying to rule out a classification, particularly derangement, it would be more beneficial to go right into mobilization, test it out, and see what the effect of that to the baselines, and then decide what to give them after that.
Mm-hmm. Dave, do we ever see that we've had little to no response, certainly no red lights from an unloaded patient-generated force at a knee, and then we go to partially loaded and they get worse, and we go to some kind of fully loaded with additional force and they get better, where it actually doesn't quite fit the progression?
Are you asking me?
I was asking Dave. There
Oh,
you go. Sorry. Wake up, Dave.
No, my system went down for a second, so I missed a bit of that conversation. Yeah, no, I've seen that on several occasions. You know, the progression of force doesn't always fit the blueprint. Sometimes unloaded can be bothersome, and they need to have the joint loaded. Sometimes partially loaded can be ineffective, but it won't happen until it's being loaded. So I really, you know, don't be very afraid to look at changing the load, and looking at alternate loads to get a response. You'll often find you're getting a partial response in a direction. So you've kind of got the direction, and then it's about manipulating the force. You need to be unloaded, loaded, partially loaded, and how do you move in that direction? One thing that I'm over the past few years that I think all of us are probably using a lot more is the use of resistance into that direction. So don't be afraid to explore different loading strategies when previous strategies have either been ineffective or even potentially worse.
Mm-hmm. We had a question that was directed toward looking away from the knee joint. Maybe we don't go to the extent of working on right great toe extension for left carpal tunnel symptoms, but do we look at the ankle and the hip on occasion with a patient that's complaining primarily of knee pain? Cora?
I have never done that. Not to say that it's wrong, but I'm always thinking, okay, so the knee can send signals down into the leg unless the patient is wired differently. Maybe it'll shoot up to the hip, but often the referral pattern would be distal. I have yet to see somebody who has a localized knee pain coming from the ankle. Now, I may have seen somebody with a hip problem referring pain into the knee. So then if they complain primarily of knee pain, but they also have some underlying hip pain, then I would look at the hip pain baselines as well.
Mm-hmm. Do we see an influence, however? Maybe it's not as a result of a problem in the ankle or the hip, but is there a lack of mobility that then could cause that limb to load differently, and the little birdie that's telling us something's not right is the knee? You know, this is more of, I think, from my estimation, this question being asked, do we look at the hip and the ankle from that kinematic chain? And do we see that possibly the knee is being affected because of some lack of mobility above or below? Perhaps it's just very few and far between, or anyone else want to tackle that one? Gary?
I'll take a shot at that. Number one, I glazed over whenever you started talking about all that, Jason.
Don't let me keep you up, Gary.
Yeah, no, it's like, okay, I'm writing it down as fast as I can. I'm going, okay, this just doesn't make any sense, Jason. But it's always top down, so it can't be And we talked about, going back to the very first 5 minutes of this, Scott mentioned it, I think Cora, Dave, I mean, everybody talked about being methodical. It's a top-down assessment. If you got that person in there, you need to start at the lumbar spine, work down, and if you find things that seem to be relevant to the complaint, then address them. If it's not, then don't make them up. Because just because they don't move the way you think they should move at a certain joint doesn't mean it's part of the problem either. So don't make more out of something than it should be, I suppose is what I'm saying. So I'm like Cora, I rarely ever see those pop up at me. If it is, it's probably something that can be logically explained just by moving back up towards the spine again.
Well, I remember even you had mentioned before on a previous case that you test distal to proximal and then you do repeated movements or start loading strategies proximal to distal. That had to have come from someone else that sounded much too intelligent, but that does give us a bit of context and structure, I think,
So when you start talking down that path, it's like, okay, how do we make this make sense? For me, the Southern way.
That's
so
right.
I think we're going to have to talk about a non-McKenzie approach, right?
That's right. All right, let's go to a bit of the patient education. Patients want to know what's wrong with my joint. Scott, Brian had a bit of question. He was more happy with the reaction that he did see a change in the session. That was probably his dominant appreciation for it, and so he didn't question. But we do have those patients that ask, what's wrong with my knee and what's happening? Do we go pathoanatomical if the patient presses us? How do you handle that situation?
I think there's a lot to be said for reading the patient. Somebody who is already pathoanatomically focused, and for instance, if they say, well, this fixed my whatever, and I've got a derangement and it's a directional preference confirmed, sure, it'll fix your whatever. I go with the flow. I'm not going to get into a debate with them. If they don't have that pathoanatomical, internet search mindset when they come in, then, we give them analogies, the joint's not moving properly. And even there are even times where I don't even go that far with a patient. It's just, some patients are quite happy. I say, look, I'm not here to tell you what's wrong. I'm here to see if we can fix you. And this exam right now is showing that this is if somebody's markedly improved right off the bat, I say, look, I'm not quite sure, but that's not the point of this. This is to show you what we can do for it. And I've probably in my career asked thousands of patients, if you're better, do you really care what it is? And I don't think I've ever heard a patient say, yeah, I really want to know what it is. I mean, they really want to be better. And I think if you show them how to be better, most people, there's always exception to the rule, but most people are going to be happy with that.
Good. Any other comments on that? Is there ever a need in your mind to come to some type of anatomical or physiological solution in terms of what's happening with a knee derangement? Is it truly mechanical matter that's obstructing movement and then it's been pushed out of the way? Or do you resist that urge to have an answer in your mind? Dave?
I just don't really think or talk that way, I guess. Yeah. I mean, coming back to the previous question, it was like, if people are pushing and pushing and pushing, and it looks and acts like a potential meniscal problem, I might talk about that, but I just divert away from it. I sometimes, some patients will talk, and I talk to some patients saying, all joints, because what is it? What is it? It says, the joint's it's not working right. It's not hinging correctly. And I talk about lots of hinges, and I sometimes will drop in if people are searching for some form of explanation. So all hinges contain naturally occurring floaters, and sometimes these things get stuck in the way, and we're just looking for the direction of motion that gets it out of the way. And most patients are satisfied with that, but I try and stay away from the anatomical.
I think that I think more clinicians, especially in classes, my experience with it, I think that the clinicians that we talk to, I engage with, have more of an issue of the explanation than the patients do.
Yeah, I'd agree with that. What's happened? They want to, when we see a derangement that gets rapidly better, they want to know what happened.
Yeah.
The patient's going, this is awesome. And the therapist is going, what the hell
You're
happened?
great. That's
What's going
magic.
on? And they want to know what's going on within the joint. And I always say we can make stuff up. I can give you some form of theoretical explanation, but I could probably give you 3 different explanations. Who knows what it is? Is it motor control? Is it something caught in the joint? Is it meniscus? Who knows?
Gary, I love that. I'm going to use that.
What's that?
Yeah.
That the clinicians are usually more concerned about it than the patients. That's absolutely
That
true.
is so true. Yeah.
Never thought about it in those terms, but that's a brilliant comment.
Mm-hmm. Who'd you steal that from, Gary?
No, I'm just sitting here thinking about the difficulty.
I told him earlier.
Yeah, Dave and I spoke earlier. I just beat him to the draw.
All right, I'll get on the line with Dave before we start next time so I can sound smart like Gary. All right, we've handled a lot of the questions that have come up. Am I forgetting any? So you guys have reviewed some of the questions beforehand. I think we've tackled the majority of them, the spine screening, gleaning information from the history, the mechanics of testing at the knee. What about the prevalence of using any frontal plane, transverse plane motion along with extension or flexion? Is that common? Do you see it? What are you commonly seeing? Gary?
Oh, I was on. Okay. I there's a couple of things. One thing I'm going to add to what Scott did on that video is that, and I think this is another issue that I think we all are guilty of at times, is that we all try to hit that, clinical home run. And so, Robin in an original text was indicated like, once you see change and you can classify, there's no further testing necessary. So don't be in such a hurry, because sometimes you'll mess your own self up, So if you think, oh yeah, transverse plane, let's add some rotation in there with that, that extension, let's reposition the foot. The question then is, why should you reposition the foot? If they're moving better, feeling better, you've met your expectations and you've got a suspicion, you should send them away and test that. You may not need anything else. So I think that I find the need for those additional, pre-positions, if you will, a lot less necessary now than I did 10 years ago, because I'm a lot more patient with, what they're going to bring back to me the second visit. And so I would say that, occasionally you might find the need to look at that, but it's on the fact that you've got no change or worse. So, if you get a yellow, flag or a yellow light or a red light that tells you need something different, then address that. But if you don't, then I think there's very little need to continue to push for a greater change when you've already got a good change.
Okay. When you're hitting a persisting yellow light that's almost turning red and you've stayed in the sagittal plane, is there any common direction that you're seeing? Is it external rotation? Is it internal rotation? Is there some kind of varus or valgus hand positioning change, or do you guys see the need for that very often at all? Cora?
Often in the knee, just like Scott said earlier, the knee is very much like the spine, right? So often you will find the direction in the sagittal plane, but in the knee, what we find to be the common directional preference, if they do not respond to straight up extension or flexion, is usually an addition of external rotation of the tibia. So the extension and tibial external rotation are often coupled. So it's just like in the lumbar spine, if they have a relevant lateral component, then you incorporate the hip soft center. So in the knee, typically extension with external rotation of the tibia. So that's my 2 cents for the knee.
Dave, any deviation from that? No. I mean, that's kind of the go-to. I think I can probably think of I've maybe had like 1 or 2 patients that need internal rotation, but it was combined with flexion.
Yeah.
And again, I do see a few flexion responders, and not many. I mean, extension is by far the dominant direction. But like I said, I mean, I saw a few, and again, I went through a phase of thinking this might have been a bit of a trend, but I haven't really seen it kind of pan out that way. I saw quite a few female runners, kind of the younger crowd, 18 to 25-year-old. I had a whole stream of them coming in that were flexion responders, and I had a few that had kind of like, it was a green light, but it wasn't better, and that I still recall a couple of patients that it wasn't until I actually flexed them with internal tibial rotation they would do. But again, we're talking about a very, very small number of patients.
Sure. We got a question here that Scott, you asked about pain going up versus down the stairs. What do you like to gather from that? If the patient says, "Oh no, it's much more problematic for me going downstairs versus up, or vice versa."
Yeah, more pain coming down. That's a greater load on the contractile structures. So if they'll tell me going up, not a problem or a smaller problem than coming down, that pushes me a little bit more toward a contractile, possibly a knee extension contractile dysfunction.
Okay. To the panelists, Gary and Cora and Dave, some of us that are watching this may not even pick up on a real key principle that you observe, or that we observe Scott doing, and may not even register that that's an important concept. Do you remember anything about this first video that you saw Scott do, or that you saw him react, or that you saw the patient mention that Scott knew to respond in a particular way that you just would like to highlight for the benefit of the listeners? This is a question that really puts you on the spot, whether you were paying attention or not during the video, right? Gary?
Or whether they think I did anything right.
That's right, yeah. Was there anything worthy of talking about that Scott did in this video?
Did it clear the
I
spine?
think the subtlety to all of it.
Not doing posture correction for the patient.
That's right.
No, he didn't say the things that were done wrong. He said the things that were done right.
Oh, okay.
Okay, right.
I think, Gary, it's your turn.
Yeah,
See, they're all
right.
speechless. Once I qualified your question, Jason, they're all speechless.
That's right. Well, this was 7 years ago, like you said, so you've had time to develop into a reasonable clinician since then, right?
I'm still working at it.
Yeah, I think the thing that Scott is doing the entire time he's working is trying to determine a classification, and does his, curiosities or his expectations, are they met? I think the whole time he's doing this, he's never once treating anyone. He's not treating him. He's trying to classify him and understand him. I think that's the subtlety to the examination, is that, the entire time he's asking questions, and the entire time he's having him move and he's reassessing him, he's looking for, am I meeting the expectation of this suspicion or the hypothesis I developed? And I think that's the subtlety to what, I guess Scott's doing, what we all should be doing.
Yeah, that's what I was going to say too. Just listening to Scott ask questions during the history reminded me of Robin McKenzie. So that's a really good compliment to you, Scott, because he would ask, oh, okay, I know. But he would ask questions with the intent of classifying, right? So he wasn't just asking questions based on the form. So he would say things like, okay, so does the stiffness, does it vary? Things like that. So when the pain comes on, when you run, when you quit, does it linger, or does it, so a lot of the things that he would ask are not necessarily confined by the form. So I think it's something that takes time and experience to gain. It's a skill. And okay, I'm gonna stop right there because Dave is giving me the look.
The check's in the mail, Cora. Thank you.
No, I mean, again, actually, what Gary said. I mean, I actually even looked at and took some notes.
Oh, there you go.
Rest.
Now I've had this video on a flash drive for probably since he made it 7 years ago, and if you've taken a class for mine, I think I probably showed it maybe a couple of times, and I think the reason why I don't show it as often is probably because it's a series of 3 videos and it's just the time. It's time intensive. It kind of pulls up a lot of time. It's a nice video, and I'm sure, and I actually thought that was the reason why we didn't screen the spine. I thought the spine was screened ahead of time. Let's get down to the nitty gritty and let's get to the joint. But just as he went through the history, as I'm watching Scott question Brian, I'm on this. I mean, we're thinking the same things. It's like location, classification, direction, and force. And he's asking, well, where do you hurt? My knee hurts. Does your back hurt? Your hip? Your thigh? It's my knee. Okay, he's thinking knee. Well, how long does it hurt for? Well, it's been 3 to 4 months. Okay. There's no trauma. Well, what's the status of it? Well, that's been getting a bit worse. It's intermittent. And it's just, and again, back to methodical. He's got a methodical way of pulling the information out of the patient and going, okay, but he's not thinking about, oh, I wonder what this might, what I might do. He's planning. He's like 5 steps ahead of the patient already about how he's going to address this patient. At that point, just based on all the information, it hurts going up and down stairs. So articular dysfunction's out the window. Is it contractile or is it derangement? And he's asking those follow-up questions. So when you go for a run, does it come on immediately? When it does come on, does it shut off immediately? Is it bothersome the next day? Try and get some indicator. Is this contractile or is it a derangement? As soon as you does the physical exam, contractile left the building. There's a massive loss of motion. So then it's derangement, and the question is, well, which direction do I go in? And then based on the past 1,000 knees he's seen, based on the clinical presentation, based on what the patient is telling him, he's looking for a direction, and he starts moving in a direction. He gets a response, and let's run with that. And then 2 more videos to come.
There you go. Yeah. Now, thanks for summarizing. You're right. I appreciate Scott's ability to relate to his patients. I always have admired that when I've gone and seen him on the clinical decision-making courses, the CSUs that were previously known as CSU, how Brian, I think, has to feel trust, in Scott. And that's something that I think you don't learn in the McKenzie text as much. You learn just through relating to patients, and obviously you can learn from Rob and from how he did it. For those of you who were able to observe him, but I appreciate that with Brian. There are 2 additional videos that we'll be releasing, one this week and one next. So for all of you listening out there, make sure that you keep watch for your emails that will have the links to those videos. We'll have another Q&A 1 week from today, same time, same place, if I haven't run everyone off yet in terms of our panelists. And we'll continue having a good discussion like this. For those that we didn't get to, the questions that we didn't get to, I'll direct you to a Facebook group page that we can continue the discussion, and we can have that discussion ongoingly for this next week to address any additional questions. But thanks to all of you who've attended live. Thanks to you who've listened at a later date on the recording of this. And for those of you who've offered questions, we appreciate it. Scott, thanks for evaluating this patient and sharing it. Thanks to Stacy for having an interest in doing a partnership with this. And then Dave and Cora and Gary, I appreciate you guys fielding these questions. And we'll see you all in about a week.
Jason, thank you very much. And I think I speak for all of us and all the faculty and all the people in the McKenzie Institute. We need to acknowledge what a resource you are, and the work you've done over the previous years. Your work, not only that, but your volunteer work in South America with the Native Americans, and we really do appreciate you.
My pleasure. Glad to relate with you guys, being able to hang out with the cool kids tonight. So on that note, we'll conclude. You guys have a great evening, and we'll be back in touch in about a week.
Thanks, Jason.
Thanks, everyone.
Thank you.
All right.
Thank you, man.
Cheers. Bye.